Hi everyone, welcome to session 3. This session focuses on post-operative complications that you might encounter as a foundation doctor when you're working on your general surgery rotations. I based these off complications that my patients had experienced when I was a foundation doctor on general surgery. So I thought that these would be really helpful for other people to know. Maybe you are currently a foundation doctor, maybe you're starting your foundation next year. So what are the aims and objectives of this session? So firstly, it's to revise the main post-op complications which you may encounter as a foundation doctor, to discuss the management of post-operative complications, to recognise when to alert a senior doctor, and to have a robust framework in order to approach these post-op complications in a really systematic manner. So the first one that we're going to focus on is hemorrhage. And so there are different ways that we can classify a hemorrhage. Sorry, just having my cup of coffee. The first one is primary. So that'll be a direct trauma to the vessel and bleeding that starts during surgery. You can also have reactive hemorrhage. So that's bleeding at the end of surgery or very early post-operatively. And that's secondary to the increased cardiac output and blood pressure once anaesthesia is ended. So during anaesthesia, the anaesthetist will be tightly controlling the blood pressure. However, once the patient comes off anaesthetic and the blood pressure comes back up, there might be bleeding secondary to that. The next is secondary bleeding, and that's bleeding that occurs over 24 hours post-operatively. This is the issue that you might commonly encounter as a foundation doctor when you're doing your ward round the next day, for example. So we can also have different skin wounds that we classify. So there'll be a clean wound. So that's when the procedure doesn't enter a colonised viscus or a lumen of the body. So for example, this would be something like an inguinal hernia repair, a mastectomy, a joint replacement. Whereas a clean contaminated would be when the procedure enters a colonised viscus or cavity of the body, but under elective and controlled circumstances. For example, an elective colorectal resection. So unlike the inguinal hernia repair, we haven't directly gone into the bowel itself. We're just putting the bowel back in place with the inguinal hernia repair. Whereas now we are going into the bowel, but because it's elective and controlled, there's been some bowel prep. However, with a contaminated wound, there is gross contamination present in the absence of infection. For example, going into a perforated diverticulitis or a perforated appendicectomy. So that's when there's a contamination at the surgical infection, and when it's usually not in elective circumstances. The next will be dirty skin wounds. So this is when there's an active infection present. So intestinal perforation, chronic pressure ulcer debridement. And this classification is really helpful in guiding us as to when antibiotics are needed. Typically, whether or not to start antibiotics will be something that's included in the post-op notes, and that's something that's really important as the foundation doctor, especially if you're on on-call shift, looking after patients in the evening, to go over the post-op notes for patients who've had operations that day, and just look over who needs to be started on antibiotics. Typically, the anaesthetic team will give the first dose of antibiotics or any antibiotics that they need on induction, but it will be up to you or the SHO looking after the patient after that to start their antibiotics for the coming days. So wound infection is a common post-operative complication, and it usually occurs 5 to 7 days post-operatively. The clinical features in Latin, calor, dolor, rubor. However, in plain English, which is what we're more interested in, is heat, pain, erythema and swelling, and there might also be some discharge and pus. It's most commonly due to Staph aureus, but it's useful for you to culture take a swab or a wound culture so that you can have appropriate sensitivities and specificities for the pathogen that's present. So there are certain risk factors that are present that lead to a wound infection, and this would make a really good question for a surgical OSCE station. So the first is preoperative factors such as age, comorbidities such as diabetes or vascular disease. If the patient's colonised by MRSA, so typically patients should be tested for MRSA prior to surgery, and if they are positive for MRSA, they can undergo an MRSA decolonisation protocol. your trust should have guidelines on that, and if the patient has any pre-existing infections. There are also operative risks, so the type of operation, whether it's an emergency operation, whether there's a laparotomy involved, the duration of the operation, if there's any technical features of the operation, so whether there's been good hair removal, whether the aseptic technique has been used, and then post-operatively, whether there's been good or bad wound care, any comorbidities that the patient might have, diabetes, smoking, immunosuppression. So how do you, as the foundation doctor, manage a wound infection? You want to ask the nurses to take swabs and send. You want to start them on antibiotics, either starting broad and then focusing based on the sensitivity and specificity, or discussing with microbes to see if the patient's previously been colonised by other bacteria. And you want to remove any skin clips and perform incision and drainage if indicated. So wound dehiscence is when wound edges separate, and that can occur 7 to 10 days post-operatively. This can be superficial, so the skin wound alone, or it can be full thickness. So in this case, it will be, for example, the rectus sheath is unable to heal. So the clinical features here would be a salmon pink serosanguinous fluid discharge, a bulging wound, and evisceration. And we have the key risk factors on this slide. So in terms of patient risk factors, there are comorbidities such as diabetes, cancer, chronic kidney disease, chronic cough. Older patients are more likely to have wound dehiscence. Any steroids, radiotherapy, chemotherapy, obesity, smoking, malnutrition. These are essentially factors that make your skin composition less likely to heal. There are also intraoperative factors such as emergency surgery, a dirty operation, a long operation over 6 hours, or a poor technique such as suture choice or inadequate tissue bites. What we mean by inadequate tissue bites is, imagine if you're sewing together 2 pieces of fabric, or in this case skin, it's not having enough distance from the incision site to the point at which your needle goes in. And if this is too close together, then it might fray or break off and then therefore not have good skin apposition, so the 2 sides of skin coming together, and therefore you don't have a very good seal. The post-operative factors here are wound infection, so this is the most common cause, prolonged ileus or any other cause of abdominal distension, prolonged ventilation or excessive patient coughing. And this is a really good structure for presenting the risk factors, so patient factors, intraoperative factors and post-operative factors. If you don't like the structure, it doesn't really matter, but just having any sort of structure in order to present your complications or risk factors is a really good way of just organising them in your mind. So next we have the management of wound dehiscence. So if it's superficial, you want to wash the wound with saline, potentially pack the wound with an absorbent ribbon gauze. There may be a vac dressing needed if extensive, and then we want to encourage healing by secondary intention. So what does this mean? This is when a wound is left to heal by itself, so it's left open instead of being stitched together. And this happens when the edges of the wound can't be brought up together. So in essence, the wound sort of heals from the bottom to the top of the wound. In cases of full dehiscence, you need to have a different approach. So you want to keep the patient nil by mouth, give them analgesia, IV fluids, and IV antibiotics. Typically, you want to give them coamoxiclav and metronidazole, potentially with gentamicin as well. You want to cover the wound in sterile saline soaked gauze and replace the contents. You also want to cover any bowel. You want to return the patient to theatre, perform a washout, and also debride any of the wound edges. This is really difficult to manage, so obviously this would be something that's very senior and consultant-led. So the next situation that we have is post-operative ileus, which we previously mentioned as one of the risk factors for dehiscence. So in this case, the causes could be the bowel being, it's caused by the bowel being handled, any electrolyte imbalances, anaesthesia, any collections that are any intra-abdominal infections. And the clinical picture that we have here is abdominal distension, vomiting, absent bowel sounds, and constipation. So this very much presents like bowel obstruction. And in fact, ileus is one of the differential diagnoses for bowel obstruction. In order to manage these patients, you want to drip and suck. So by drip, we mean an IV fluids with electrolyte collection, and by suck, NG on free drainage. If the patient has prolonged ileus, you want to be considering TPN and getting the dietitians involved. And it's really important to differentiate this from obstruction. The next complication that we have is pulmonary atelectasis. And this will really be a case of shared care between the medical team and the physiotherapy team. So atelectasis commonly occurs after most general anaesthetics, typically within 24 to 48 hours. So the theory suggests that there's airway collapse due to a combination of airway compression, alveolar gas reabsorption intraoperatively, and impairment of surfactant production. So the risk factors here are having any pre-existing lung or neuromuscular disease, such as COPD, bronchiectasis, asthma, obstructive sleep apnea, smoking, obesity, advanced age, or any thoracic or upper abdominal surgery. There may also be risk factors related to poor post-operative analgesia or prolonged immobility. The patients will present with shortness of breath, reduced saturations, and dull lung bases with diminished or absent breath sounds, and they may also have a low-grade fever. So prevention is the best treatment, which is why the physios is so important here to really encourage patients to do chest physiotherapy. You want to avoid any narcotics that diminish the cough reflex, have early mobilisation, good analgesia, and encouraging patients to cough and take a deep breath. It might also be useful to use incentive spirometry, and if that's not available, you can literally ask the patient to blow into a 20ml syringe and see if they can push the plunger back just with their breath. What you need to do before this is just release the back of the plunger just a little bit so then it's able to move, and just ask the patient to do that a couple of times an hour. I found that really helpful if the ward doesn't have any incentive spirometry. Patients may need supplemental oxygen, but as I said before, prevention really is the best treatment with this. The risk factors here are males of increased age, any neuropathy, so alcohol excess or diabetes, benign prostate hyperplasia, having specific surgeries, so hernia surgeries, urological surgeries, or any surgeries involving the rectum, anaesthetic type, so particularly spinal or epidural, and medications such as antimuscarinic medications, alpha agonists, or opiates. For the investigations here, you want to perform a clinical examination, a bladder scan, and check the usinase. So conservative measures here might be offering the patient some privacy, encouraging them to move, running some taps or a hot bath or analgesia. Typically, this will fail and the patient needs a catheter. Once you want to have a catheter removed in hospital, you want to TWOC, so that's a trial without catheter. If the TWOC fails, so for example, the patient's in retention, you put a catheter in, the patient starts passing urine, you want to send them home, you take the catheter out and they go into retention again, you put the catheter back in, you send them home, and in 2 weeks' time, you reattempt the TWOC at TWOC clinic. You also want to assess for any reversible causes and consider starting tamsulosin. So the next, which is a very big one in surgery, is VTE. So all patients should be assessed on admission and reassessed within 24 hours, and if there's a change in any clinical condition. This is a really good surgical audit for anyone interested in performing any audits to look at the rate of VTE assessment in your department. So why is VTE such a risk, especially in surgery? So we have endothelial injury, stasis of blood, and hypercoagulability, all of which contribute to an embolism forming. So the risk factors here are prolonged immobility, recent surgery, being pregnant or postpartum, using the oral contraceptive pill or HRT, having had a previous embolism, or having a current malignancy. So if you think about an elderly patient who's just undergone bowel surgery and for a cancer, they fill a lot of those risk factors. So especially if you're doing a general surgery rotation, a lot of your patients could be very high risk for this. So what are the clinical features of VTE? So the first, for DVT, we have unilateral leg pain and swelling, a low-grade fever, pitting edema, but actually a lot of patients are asymptomatic. And what about a pulmonary embolism? These patients will be short of breath with pleuritic chest pain. Haemoptysis is rare but possible, and they may also have a high heart rate, a high resp rate, and an elevated JVP. So how do you investigate this? So you can perform a Wells score, so a DVT Wells score or a PE Wells score, and I recommend using MD Calc for these, and also an ultrasound scan for a DVT and a CTPA for a PE if indicated by the pretest probability scores, so the Wells score. You might also want to do a VQ scan instead of a CTPA if the patient is pregnant or has poor renal function. ECGs may show tachycardia, and they may sometimes show key features such as right bundle branch block, right ventricular strain, S1, Q3, T3. However, the most common finding for a PE is just sinus tachycardia. A D-dimer is sensitive, but it's not specific, and it will be elevated in so many different cases. So surgery, inflammation, infection. So a D-dimer is useful for sort of saying, ruling in that a PE could be a possibility, but not saying that it's definitely a PE. So VTE prophylaxis should be given to all patients having joint replacements or cancer surgery, and that's normally for 28 days post-operatively. Most patients who you have on your surgical wards will need some form of VTE prophylaxis. This may be in a mechanical form, such as TED stockings or flotrons, or pharmacological, so low molecular weight heparin. In our trust, we use tinzaparin. If the renal function is very poor, so an eGFR of less than 30, consider using unfractionated heparin, and also really consider the weight of the patient before dosing. So especially if patients are overweight, they may need twice a day, so BD tinzaparin, and that's really important just so you are properly anticoagulating your patients, not undercoagulating them because of their weight. So we've spoken about VTE prophylaxis, and now it's time to speak about VTE treatment. So you want to give the patient therapeutic low molecular weight heparin, and that dose will be based on their weight. And you should have trust guidelines that will tell you how to dose for this. This should be given if a DVT or PE is suspected. So for example, if you've got a patient that you think they've got a PE, you give them the low molecular weight heparin straight away without waiting for the CTPA if you've got a high clinical suspicion of this. This is because sometimes it can take a few hours to organise the CTPA, and you don't want the patient to be becoming unstable in that time. It is common to give patients DOACs, that's normally first line, but these don't require bridging. In some patients, warfarin may be used, however, this requires bridging with low molecular weight heparin. The duration of the treatment depends on the location of the DVT, any risk factors, and if it's recurrent. If it's the first episodes, there's transient risk factors such as surgery or trauma. You only want to continue with the VT for 3 months. But if it's recurrent, unprovoked, or there's ongoing risk factors, you want to consider for over a year. And you want to contact the anticoagulation clinic before the patient is discharged. So next complication is an enterocutaneous fistula. And this essentially is an abnormal connection between the intestinal tract and the skin. So think of it as an unplanned stoma. The clinical features are having any enteric contents, so any bowel contents coming out from the drain site or the midline wound. So also if there's low output, it can be low output, moderate output, or high output. And the complications here is sepsis, peritonitis, dehydration, malnutrition, electrolyte imbalances, because if you think about it, you're not absorbing all of the electrolytes and nutrition that you need. The skin might break down, for example, if you have like damaging bowel contents that are leaking onto the skin, and also death. So it's really serious. The way that you manage this is using the SNAP protocol. So at first you want to assess sepsis, so control this with antibiotics, rehydration, and drain any abscesses or collections. Nutrition, so consider supplementing oral intake with ensures or NG feeding, and this may increase the fistula output, so TPN might be needed instead. You want to define the anatomy of the fistula using imaging, and you want to plan your surgical approach and have a plan B as well. If there's very high output, you might consider octreotide to reduce the output. So the next clinical scenario that we have is a post-operative fever. Your differential diagnosis really depends on when the fever starts. So if it's early, so 0 to 5 days post-operatively, it might be due to a blood transfusion, physiological fever, so that could be a systemic immune response to surgery, a basal atelectasis, which we've mentioned before, and any infections such as UTI, a line infection, so from a peripheral or a central line, a hospital-acquired or a community-acquired pneumonia or an aspiration pneumonia. You can also have a late, so over 5 days post-operatively, so a wound infection, a HAP, a DVT, a PE, or a leak. A collection can also occur anytime from surgery to around 3 weeks post-operatively. So how are you going to manage these patients? Remember the sepsis 6. So you want to take bloods, you want to take urine, you want to give the patient fluids, you want to look at their lactate, give them antibiotics, and give them oxygen as well. You want to take any wound swabs from MCNS and any stool cultures if needed, a chest x-ray, and you also might need a CT-AP for any intra-abdominal collections. You want to look at the op notes as well to see if there's been a particularly difficult procedure. Maybe there's been some bile leak or there was a collection noted intraoperatively. If there were any samples sent to the lab during the operation, that would be useful as well to tell microbiology about. In these patients as well, it's really useful to review the drain output and to monitor these as well. So managing the septic patient, as we've spoken about before, it's really important to remember the sepsis 6. So oxygen, fluids, antibiotics, and having really good chest physio, good positioning, mobilisation. And if you think there's a wound infection, again, you want to remove the clips and allow drainage. So an anastomotic leak. So how will this present? So if you have fever, tachycardia, and raised inflammatory markers on day 3 to 5 after any colonic surgery with an anastomosis, you are suspecting a leak until proven otherwise. The risk factors here for the patient factors include age, advanced age, male gender, smoking, increased alcohol, obesity, malnutrition, and low albumin. In terms of their comorbidities, you're thinking about vascular disease, renal disease, pulmonary disease, diabetes, any immunosuppression, so in this case steroids, methotrexate, any mycophenolate, and pelvic radiotherapy. In terms of operative factors which would contribute to this, any perioperative hypoxia or hypotension, a long surgery, use of vasopressors, contamination, any need for transfusion, or any failure of technique. How do we manage a leak? Firstly, there's conservative management, so antibiotics, and this is appropriate if the patient is not overtly septic and their abdomen is soft. If there's any contained leaks, you could do a radiologically guided aspiration or a laparoscopic washout and placing a drain. However, if the patient is septic, needing inotropic support in ileus or peritonitic, they need a laparotomy to resect the anastomosis and to form a defunctioning stoma. So next we have a post-operative patient presenting with shortness of breath or low saturations. And our differential diagnosis here is any pre-existing lung disease, a PE, chest infection or basal atelectasis or aspiration pneumonia, an MI, a pneumothorax, especially if they've had a central line insertion, poor analgesia or abdominal distension. The investigations and management of post-operative shortness of breath or low saturations include a chest x-ray, ABG, or an ECG or a CTPA if you're suspecting a PE. And you manage these patients by high flow oxygen, repositioning them, so sitting them upright, giving them chest physiotherapy and any IV antibiotics, good analgesia. Also, you might want to give them an NG tube to decompress a distended small bowel, and any treatment dose, fragment or low molecular weight heparin if you're suspicious for a PE. So lastly, we have a post-op patient with reduced urine output. So oliguria, reduced urine output, is less than 0.5 ml per kg per hour, and anuria is 0 ml per hour. So the causes for this can be pre-renal, so hypovolemia, so if they're bleeding or if they're dehydrated or if they're septic. Renals, that can be caused by nephrotoxic medications such as NSAIDs or gentamicin, or post-renal, so if there's been any injury to the ureter, a locked or malpositioned catheter, or acute urinary retention. Always make sure if you've got reduced urine output that the catheter is actually unlocked. If you don't know how to do this, I ask a friendly, kind nurse to help you out. So how would you investigate these patients? You want to check the observation chart, review any input-output, review the op notes, examining the fluid status, examine the abdomen for a palpable bladder and perform a bladder scan, and check drains and any stomas. You also want to flush the catheter and aspirate back and check that the catheter is flushing, and also perform a fluid challenge. So how are you going to manage the patient if it's urinary retention? Again, this is something that we spoke about before, but you can, try conservative measures, but realistically, they're going to need a catheter. You're going to attempt TWOC. If TWOC fails, they can come back to TWOC clinic. And thank you so much for listening. As always, here is the feedback link. It would really be amazing if as many of you as possible could fill in the feedback link, just so I know how to make sessions better and improve it for you, and also improve my teaching skills. So thank you for coming to this session. I really appreciate it, and I really appreciate your time.